In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Roger McIntyre about adjunctive treatment strategies for major depressive disorder. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast. Let's listen in as Dr. Cutler and Dr. McIntyre discuss the current research on adjunctive treatments for major depressive disorder.
Hello and welcome to another NEI podcast. I'm Dr. Andrew Cutler, Chief Medical Officer of NEI, and today I have the distinct pleasure of speaking with a good friend of mine and a real expert, one of the world's leading authorities on the treatment of mood disorders, including depression, and that's Roger McIntyre. Roger, how are you?
Well, Andy, thanks for that kind intro, and always fun to work with you and have these types of conversations. So nice to be with you for the podcast.
Yeah, I certainly agree. And speaking of this, this is really an exciting area of development for new treatments. There is a lot going on. I've been doing research for 30 years, and this is one of the most fertile periods that I can remember.
Yeah, I think there's a correlation, Andy, between the amount of gray hair you and I are getting and the amount of new medications that are starting to look very promising. No, I agree. I think it's a fair comment, Andy, that I think I've always say we've been in a bit of a cul-de-sac for a little while, but I think that cul-de-sac now has really interesting lines of sight, and not just lines of sight that are theoretically interesting, but in some cases ready for clinical application. So I think it's very helpful for the field, and it's been intellectually and academically very interesting.
Yeah, I would think some of this parallels the major advances in technology that allow us to understand the neurobiology better, don't you think?
Absolutely. I think that's probably where, that whole issue about can we develop new medications informed by the disease process? I suppose you could say esketamine and maybe even brexanolone, glutamate and GABA drugs were in many ways derived from a disease model. So we're now beginning to put the horse in front of the cart when it comes to treatment discovery and development.
Yeah, I agree. In thinking about our careers, Roger, really we've been witness to what I would consider two major nodal points in the development of treatments. The beginning of the modern era was in the 1950s, obviously, with the tricyclic antidepressants and the modern the first generation antipsychotics. And then obviously the second generation came about in the late 80s and 90s with the atypicals and the SSRIs, SNRIs, and I think we're on the cusp of the third wave, if you will.
Yeah, I think you're right. And I think what we're talking about not only is mechanistic innovation, like targeting, receptors and molecular systems that historically have not been, if you will, sort of, receiving the streetlight effect. But I think what we're also talking about, Andy, when you and I first started in this field, there almost was this just acceptance that we had to wait 6 weeks for drugs to work. And I think in addition to innovation on what are the new targets, I think people are saying, we should be able to get people better within a week. I mean, why are we waiting so long? I think there's a sort of a rapid acting type genre that we've moved into.
Yeah, it's a real paradigm shift. And there's important implications for how we monitor these medicines and what we tell patients and things like that. All right, well, let's get going with our topic here. We're really talking about adjunctive agents. And so we're really talking about the concept of inadequate response or treatment-resistant depression. So first of all, let's start out with a definition. What are we talking about here when we talk about these conditions?
It's a really important point. I think it does begin with defining what we mean by response, remission, or for that matter, non-response. And I think one sort of philosophical shift is we're moving increasingly towards patient-reported outcomes and patient-centric measures. All people joining us for the podcast have really heard us talk a lot about measurement-based care in quantifying objectively patient outcomes. It helps sharpen the focus and guide the discussion and in many cases inform treatment decisions and selections. I think also what we're talking about is what magnitude of improvement, let's say on a patient-reported scale like PHQ-9 or QIDS SR-16 as two examples, is relevant to the person living with the disorder. And we have cut scores on these scales, and that has been an important target. But I think also from the patient's perspective, and this is part of shared decision making, what are the patient's objectives? What are the key performance indicators, the KPI, if you will, with the medicine that the patient wants to achieve? And is that achievable? So I think we talk about this quantitatively, it's shared decisions, and we do it with patients with a really a frank conversation. What are the goals of treatment? The reality is, Andy, as you know, is that with conventional first line, if you will, monoamine-based antidepressants, we don't really get most people into recovery. So augmentation and add-on is almost the rule rather than the exception conversation.
Yeah, you're reminding me of Kern de Medier's famous paper where he looked at what physicians define as recovery versus patients, and there was a real disconnect. We tended to focus on symptoms, and patient talked about things like feeling well and optimism and being in control of my life, feeling like my normal self, things like that.
Yeah, absolutely.
So it is very important to get the patient's perspective. All right, let's start with the classic, the STAR-D study. What percentage of patients had an inadequate response, a partial response, or failed to get into remission?
You know, Andy, I think that you'd probably agree with me that remission is a more stringent definition. It does imply greater symptom improvement.
I agree.
And if we use remission as our benchmark, I mean, the remission rates were about a third, plus or minus, of people achieve remission with the first treatment. With the second treatment, as you know, Andy, about a third again achieve remission. But then things changed thereafter. And I always say that once you've got two strikeouts, that third one is a real precarious situation because the remission rates were less than 15% with the third intervention. So we really see, modest, I'll keep it positive, modest at best remission rates with the first and second treatment, and certainly quite low remission rates with the third treatment. So I think clinicians who see patients know this full well. And I think patients get quite frustrated by this. And I think clinicians also get frustrated by these very low remission rates.
Yeah, I certainly agree. I think what's happened too is there's a little bit of nihilism, and clinicians sort of get into the good enough paradigm. At least I get them better, but I don't know that we're setting the bar high enough. Certainly in other fields of medicine, you would never settle with just a partial response.
That's right. Absolutely.
Okay. We talked a little bit about monitoring. What are some clues or some ways that clinicians can identify patients and monitor these patients who are having partial response? How do we help them?
Yeah, absolutely. For me, I have found it time helpful to have patients complete rating instruments. Now, of course, a lot of things are done virtually, which is also helpful, PHQ-9, QIDS-SR. So it begins with gathering quantitatively what are the actual symptoms they're experiencing. Then what I do is once I've sat down with the patient, either brick and mortar in my office or even more so virtual these days, I go through some of the symptoms and I'll say to the patient very candidly, you have these symptoms or those symptoms, but in your own words, which symptoms are most problematic for your quality of life, for your functioning, and which symptoms would you prioritize? And those are the symptoms that we put right into our crosshairs. And I would say this, Andy, that there's been certainly a theme that's emanated in my career. The symptoms tend to fall into buckets or groups that tend to be pretty consistent. I hear a lot about sleep disturbance. I hear a lot about people saying that they're very fatigued, lacking motivation, have no interest. And I have other people saying, I can't focus, I can't concentrate, I can't even organize my thoughts. Those aren't the only symptoms, but that's a very common complaint or chief complaint that I've heard in my career.
Yeah, I certainly agree. You're reminding me of something that I do. Sometimes, despite our best educational efforts, it's true that clinicians don't always use rating scales or measurement-based care, but I create my own rating scale. I'll very much along the lines of what you do. I'll ask, what are the 3 things that bother you the most? And I write them in the chart. And then every visit, I am assessing those 3 things, which is really the patient identifying what's most important to them. And it's a rating scale in a sense. It's a way of measuring.
Yeah, absolutely. Absolutely.
Yeah, really like that. One other thing I think we want to define before we get into this a little further. There have been various definitions of true TRD, treatment-resistant depression, but I think the field would probably settle on failure to respond to at least 2 different antidepressants, adequate dose and duration in the current episode. Would you agree?
Yeah, I would agree. The FDA's adopted that definition. There's well over a dozen definitions of treatment-resistant depression, but that seems to be the one that's most commonly employed. And it's the one that we use in our center.
Yeah, and certainly that's the approved criteria for the use of intranasal S-ketamine, for instance, which is the one approved for TRD now. Okay, how do we decide who is appropriate? This is also a little bit of an age-old question, but how do we decide when to switch and who's appropriate for adjunctive treatment?
That's still to this day in 2021. That's that Yogi Berra fork in the road. When you get there, just take it. You know that one.
Yes.
Look, I think it comes down to, this is where the shared decision making is. But I think that clinicians know that there's advantages and disadvantages both ways. Certainly in STAR-D, what the patients reported is that when they had some degree of improvement on the index treatment, they preferred an add-on approach. In other words, let's take advantage of the therapeutic momentum. Secondly, let's also take advantage of the fact that we have maybe more sort of focus as to which symptoms are residual. So there's advantages to that approach, clearly. Maybe the disadvantage, at least in some respects, is, of course, it introduces polypharmacy. For some people, that's not what they prefer. There's always the possibility of additive side effect potential, of course, drug interactions. I would say that for me as a clinician throughout my career, informed by my decisions that I see in clinical practice, as biased as they are, as well as the evidence, I would say that more often than not, Andy, I tend to be an add-on person. That's just been that's not philosophical or ideologic. That's just, I just go where the patients want me to go with them. And I end up in that place more than just abrupt stopping and switching over. Although I do that, but not as commonly.
Yeah, I certainly agree with you. There is some of the evidence base, if you had to choose, does favor adjunctive treatment. Yeah. And also, if you think about, our antidepressants are all kind of, as we said earlier, monoaminergic kinds of things, and most of them are reuptake inhibitors. So, what are the odds switching to another reuptake inhibitor necessarily is going to work? So I like complementary adjunctive mechanisms, if you will.
Yeah, I do too.
And that certainly includes things like lithium and thyroid hormone, but especially now the evidence base is so rich for atypical antipsychotics.
Yeah, absolutely it is. And that's why your word complementary, I think, is really important rather than redundant or irrational polypharmacy. Like, for example, I would not give a patient 2 or 3 SSRIs at the same time, for example. I would not give a person 2 or 3 atypicals at the same time. And I think it's about trying to find the complementarity and the pharmacodynamics of the atypical with the initial antidepressant. It's a really important point.
Yeah, I like that point about pharmacodynamics, because if you think about what we're doing when we add the atypical antipsychotics, we're not adding more reuptake inhibition, we're adding receptor binding. And clearly there are certain receptors that, we think may be more likely to give these drugs the antidepressant effects. What are some of the receptors that might be involved here?
Yeah, it's really interesting. I mean, it's an overly simplistic model, perhaps a bit reductionistic, but it still provides a framework for thinking. For example, we know that atypicals, and again, this is broadly as a class, there's differences, as we know, Andy, with agents within the class. But we think about dopamine. Of course, there's different dopamine receptors, and there's different activities that are described at different receptors. But certainly we know dopamine plays a key role in aspects of cognition, aspects of reward, certainly aspects of psychomotor agitation, just to name a few, very often encountered targets. Serotonin, of course, has been in our crosshairs for so long. We know its role in depression and anxiety and cognition, and in some cases may serve as a antidote, if you will, to some of the EPS potential for some of these drugs. And finally, the adrenal system, which I don't think receives as much attention with atypicals. And there's a reason to believe that by engaging, for example, the catecholamine norepinephrine indirectly through the receptor, you may in fact be maybe helping patients in an area of engagement or motivation, more sort of more energy, things like that. So these very subjective symptoms. So those are 3. But it's interesting because we're increasingly now looking at other targets that may be indirectly affected by atypicals, like, for example, maybe glutamate, maybe some other systems. But these other receptors that I just mentioned are certainly the ones most described.
Yeah, interestingly, the antipsychotics all basically block D2 receptors. So on paper, that's not an antidepressant mechanism. If anything, that's pro-depressant. But, most of the atypicals, we know the lower dose range is where the antidepressant activity is more common, and the higher dose range is the antimanic antipsychotic. So maybe lower doses allow some of these other receptors to shine through, if you will. Yeah. And particularly, you mentioned serotonin receptors. Partial agonism and even full agonism of 5-HT1A receptors is a pretty reliable antidepressant mechanism. We know, for instance, vortioxetine and vilazodone do that. And several of the atypicals do that.
Yes,
we know
absolutely.
Yeah, and by doing that, you're probably increasing dopamine release in the prefrontal cortex, for instance. Also, inhibition of 5-HT2A or 5-HT2C receptors, which virtually all of the atypicals have some degree of that. We know that's certainly an antidepressant mechanism. And then inhibition of alpha-2 receptors in particular, that's how mirtazapine works. It's inhibiting alpha-2A and alpha-2C. And by doing that, you're actually increasing the release of norepinephrine and serotonin. So, these receptors do various things. I always say a serotonin receptor doesn't just affect serotonin, for instance.
Yeah, absolutely.
There may be other things that they're doing that we don't know about. We've recently discovered the TAR1 class of receptors, for instance. And so do they have actions at TAR1? Who knows?
Yeah, absolutely. And the TAR1 is extremely interesting with respect to, the various trace amines that we have. And I also wonder to what extent, there was an old literature, Andy, I remember from many years ago, looking at the effect of atypicals on neurosteroids. Mm-hmm. And we know that neurosteroids are implicated, in mitigating anxiety and depression. This is the rationale for using, allopregnanolone type drugs in brexanolone and zuranolone type drugs. So I think that there's part of this is a bit of the streetlight effect, as you know, Andy. Yes. Where's the streetlight shining?
That's right.
And what's so fascinating is that as we've shifted the streetlight to what we call effector systems or molecular systems, we're saying, hey, this is not just targetable, but this might be a remedy and safe in some people with depression.
Right. And as you mentioned earlier, the idea here, too, is if we can go further upstream, we might get even faster response. Manipulating monoamines, there is obviously a lag here.
Yeah, absolutely.
There is some evidence, though, that augmentation with atypicals can be effective as early as 1 week. That's one thing that has been seen fairly consistently. Let's just go through the quick list of the currently available atypicals. Which ones are FDA approved for adjunctive treatment for depression?
Yeah, we have more than one now FDA approved as an adjunct. The ones that come to mind immediately would be aripiprazole, brexpiprazole, quetiapine, and I always think about olanzapine. It is combined with fluoxetine. The label reads slightly different, but it's an atypical, and it's combined with fluoxetine in a single treatment. So I guess you could say we have 4 if you just if you include that mix in there.
Yes.
And there's clearly differences, Andy, as you know, and I think treatment selection should be guided by what's the efficacy, but also safety and tolerability. Excuse me. And what we do know is that there's differences vis-a-vis weight gain liability for metabolic decompensation, like dysglycemia, dyslipidemia. Some of these agents can be, cause somnolence and sedation. Others can cause prolactin elevation. Of course, we're always aware that there's EPS and TD risks, and there's a variety of other adverse events that are described. So I think these often enter the calculation as to which one patients prefer.
Oh, I absolutely agree. It's interesting that, 2 of these that you mentioned are D2 partial agonists, aripiprazole and brexpiprazole, and they've actually been shown to lower prolactin, whereas the others can potentially increase prolactin, which is interesting.
Absolutely.
And you mentioned sedation and weight gain are big issues, especially with quetiapine and olanzapine. But with aripiprazole, the most common side effect was actually akathisia, as you mentioned, movement disorder. And really, weight gain and sedation weren't seen with aripiprazole or brexpiprazole much to that extent. None of them are entirely free of weight gain, of course. As we've seen, quetiapine and olanzapine have relatively more liability. There are some other atypical antipsychotics that do have an evidence base and are used off-label potentially. Which of the other ones would you say are evidence-based?
Yeah, when it comes to using atypicals, there is an evidence base. Again, it's off-label, but there has in fact been an evidence base, for example, for risperidone, although it's complicated by weight gain and metabolic change and prolactin. There's also a small body of literature for lurasidone, interestingly, as a monotherapy in major depression with mixed features, as an example. Lurasidone has an advantage where it doesn't have the weight gain liability or the metabolic disruption we've seen with other agents or prolactin elevation. So
that lurasidone study, by the way, as you well know, that was a very effective, a very good effect size. Really
absolutely. And Andy, you're from the Sunshine State in Florida, and the Florida Medicaid guidelines, in those guidelines, and full disclosure, I've worked with the whole team in Tampa on those guidelines. They do a wonderful group with this. And actually, lurasidone is in there mentioned as a possible treatment in MDD as a monotherapy with mix. So I think patients, we often see people who come to us where we don't really know, do they have bipolar disorder or major depression, but they've got features that look like mixed. And so that was studied about lurasidone monotherapy. Very interesting findings. So we have a couple of others that are outside the FDA indication, but do have some scientific evidence supporting them.
Yeah, ziprasidone had a study too that was
Yes.
positive.
Yes, you're right.
Cariprazine, they have a
Yes.
positive study, and they're going for the indication.
Yeah.
And then lumateperone certainly has an antidepressant signal. They have reported out positive data for bipolar depression, as you all know, and they may eventually go for that indication too. So we have a number of them.
Yeah, that's a good point. And with the lumateperone, just published in the American Journal of Psychiatry, the data in bipolar depression, bipolar 1, bipolar 2. And bipolar 2 is a closer genetic cousin of major depression. Bipolar 1 is probably a closer genetic cousin to schizophrenia. But whenever something's effective in bipolar 2 depression, that certainly captures our attention, but it immediately gets us thinking, maybe this has application to major depression as well.
Yeah, speaking of which, the only other one that is actually FDA approved for bipolar 2 is, and you may remember I'm first author on a study of quetiapine as monotherapy for depression.
Yeah, I do. Absolutely.
That was quite impressive.
Yeah, absolutely.
So some of the, what fascinates me about the atypicals is some of them have more of an antidepressant signal than others, it seems like. And as we mentioned, clearly the 4 that we talked about that are FDA approved, I'd say with the exception of olanzapine, not as much in monotherapy, certainly, or even augmentation, but certainly the other 3, aripiprazole, quetiapine, and the newer brexpiprazole, which has very excellent data as well. So we do have these options. One of the problems, besides what we talked about, the side effects and risks, of course, is the stigma of the term antipsychotic.
Yeah, it sure is. And, Andy, just broadly, psychiatry therapeutics have never enjoyed a surplus of trust. And when it comes to atypicals, the stigma of antipsychotic has been with us for quite some time. And I think it's an unfortunate naming of the category. As you know, Andy, the APA, along with the ACNP, the American College of Neuropharm, and the ECNP, the European College, and others have gotten together around a table and they've said, hey, we've got to find a new nomenclature, a new naming system for our medications. Because, much like in the world of hypertension, where drugs are, like, for example, an ACE inhibitor or a diuretic, a potassium channel. So more of a mechanistic maybe naming system would be more helpful and perhaps less stigmatizing than antipsychotics. And certainly when you look at the prescription of antipsychotics across North America and many parts of the world, it turns out prescribing for, in quotes, psychosis is often the smallest piece of the pie or a smaller piece of the pie. So it's an unfortunate name, but I do think it's amenable to psychoeducation and in discussion with patients and just preempting that visit that they're going to make to Dr. Google and read about antipsychotics. And so it's just a good idea. I find it is an issue in some patients, but it is amenable with good discussion and candid review of that.
I certainly agree. I always prophylactically discuss that because I assume they're going to see it. Dr. Google, the package insert, the pharmacist might mention it. So I always say, they're approved for psychosis, but they're also broadly approved. And, I sometimes use the analogy, if someone has a headache and someone else has sprained their ankle and they take ibuprofen, how does the ibuprofen know to go to one person's head and the other person's ankle? They don't. They just affect chemicals all over. And,
that's a good example. Yeah. That's a good example.
So, and it may be, as we talked about earlier, too, that these are different drugs at different doses. Lower doses, again, less D2 blockade, maybe allowing these other receptors to shine through and so on.
Yeah, and that's a really important point, Andy. You'd mentioned that before on the dosing. And I think that one of the ways that we often think about antipsychotics, we've all seen those in vitro pharmacology study slides, and we see differences across agents and their binding affinities and KIs. And that's important scientific data. But I think what we don't perhaps emphasize as much is that when you prescribe these atypicals at lower doses, they have a very different, not for all of them, but for many of them, there's a very different pharmacodynamic pattern. So they're a different drug at the lower doses. And I think as a guiding principle in depression, that is major depressive disorder, certainly compared to schizophrenia or mania, the dosing in major depression on average is considerably lower.
Yeah, I think a really great example of this would be the aripiprazole story. When aripiprazole was first studied for bipolar depression, they used the same doses they used in their mania trials. So they were using 15 milligrams. Sadly, as you well know, those studies failed. But then when they went for their adjunctive treatment for MDD, they used lower doses and it was successful.
That's right. Absolutely.
It's a great example.
Yeah, absolutely.
Another story we should briefly touch on is the quetiapine story, where probably people were overdosing quetiapine, and sedation and weight gain, and certainly weight gain especially, are clearly dose related. And I don't know if you know the story. It's kind of fascinating. Quetiapine, we did studies looking at mania, and the average effective dose was actually 589 milligrams. And so they rounded it up to 600 milligrams. And then when they went to do the Boulder 1 study, which I was involved with, I'm an author in that paper, there was actually a group of us, Joe Calabrese and a group of us, and I don't remember if you were there or not, Roger, but they proposed the study to us and said, we're going to use our bipolar dose of 600 milligrams. And you could literally hear the air being sucked out of the room as we all said, whoa. And so they said, okay, we'll cut the dose in half. We'll do 300 milligrams as a comparator. There was no science behind that dose. And of course, as we know, the dose, the outcome was the same. There was more side effects for 600. So then instead of when they developed quetiapine XR, they had an opportunity to study a lower dose, but they really didn't for bipolar depression. And so in further studies for unipolar MDD, they found an antidepressant signal down to 150 milligrams. And even in Rick Weissler's paper, down to 50 milligrams, there was an antidepressant signal. So I think the marketing message is always to go higher, 150 to 300. But the antidepressant signal does shine through lower. And so we can take advantage of dosing to also improve not only efficacy, but our tolerability.
Yeah, absolutely. And Andy, you had mentioned cariprazine earlier. And what's really interesting about cariprazine is, the ABCs, aripiprazole, brexpiprazole, criprazine, dopamine partial agonist. Criprazine at the lower doses seems to have more D3 selectivity over D2. And again, with that preface, at the lower doses.
Yes.
And so certainly less than 3, 1.5 to 3. But then once you start getting up to 6, or go beyond the package insert 9 and 12, which of course is not recommended, but that has been studied, you begin to lose part of that selectivity. So there's this is a very interesting aspect, because we need to use the agents in a way that's guided by the science. But I think that it's clear that for many of these agents, as you mentioned for quetiapine, we are seeing a very different signature pharmacodynamically as a function of the dose. I have found, Andy, and I don't think I'm alone in this observation going across North America, in fact, around the world, I've always referred to quetiapine as the salt and pepper of psychiatry. Many clinicians just kind of sprinkle it on their patients at a low dose just to get the flavor right,
Yes.
And the 25 to 50 milligrams for anxiety and sleep and so on. But it clearly has a different profile, that dose, and it does at 300, 600, that's for sure. But it can, in fact, have side effects of that dose, too. So we need to be aware of that.
Yeah, don't you think that I believe in the wisdom of the clinician, and I believe that we vote with our feet. And if we do something that works, we keep doing it. And clearly, there's something to that. Yeah, I absolutely agree with you. I always joke, I do the studies that get the drug into clinicians' hands, and then the real research begins. So
yeah, absolutely. Well, that's a really important point, because I think that historically we've put all this currency into randomized controlled trials, as we should. FDA requires rigorous placebo RCTs. But I think there's increasingly recognition in RWE, real world evidence. And so real world evidence is one truth, randomized controlled trials is another truth, and our decision support need to integrate both of those truths.
Oh, I absolutely agree. And particularly when you're talking about dosing, if you think about it, you can't study every possible way of dosing a drug in the clinical trials, the registration trials. You just couldn't. It would be way too costly and too many studies. So I think what happens is we come out with this recommended dosing, which is essentially the way it was dosed in the clinical trials. But I always say recommended dosing is not required dosing. What's required is to use your clinical judgment. Yeah. And often we figure out different dosing strategies, if you will.
Yeah, absolutely. And in fact, it's those types of curiosities with clinicians, with their patients, that have made advances. When Ronald Kuhn had introduced imipramine as the first antidepressant, he was just curious in his patients seeing a mood uplifting effect. Andy, you told me this story, and I remember I talked with Rick about this. Our good friend Rick Weissler gave patients lamotrigine, and Rick basically taught us that lamotrigine can help bipolar. He was the first person to report on this, which is just amazing.
It is amazing. Yeah, sometimes I once got up the courage to ask Rick about that, and it was fascinating. He actually wrote up the story for the American Journal.
Amazing story. It's
an amazing story of empiric observation, and the old Pasteur, chance favors the prepared mind. Yeah. He was noodling around saying, well, some of these anticonvulsants work, and why not this one? And then he had the experience of seeing it in some patients, trying it. I want to mention, we get to talk about dosing. I do want to mention brexpiprazole is sort of interesting because The FDA-approved doses, of course, are 2 and 3 milligrams because those are the doses that separated. However, and 1 milligram just barely missed. But if you look at the study 1 in the label, if you will, there was separation at week 1 when patients were only on 0.5 milligrams. And then the next week they were on 1 milligram, still separating. So a lot of clinicians have told me that they have found antidepressant effects at 0.5 and 1 milligrams as a good example.
Yeah, I have found the same thing with brexpiprazole, and I have used it a lot now. It does have a lower akathisia risk, it seems, than aripiprazole, and probably also a little lower weight gain. But here's what I have found. What's interesting is that we just recently, a group of us looked at brexpiprazole's data in depression. And what we found is that on items that really tap into measures of engagement, like patients feeling more spontaneous, more involved, more sort of energetic, which we broadly called engagement, brexpiprazole was particularly effective in those items. Wow. And as I step back a couple of steps, where I have found atypicals, at least some of them, not all, helpful in depression as add-ons to conventional antidepressants, helping some of the anxious agitation. Secondly, helping some of these sort of mixed features that so many patients present with. And then thirdly, trying to help patients with rumination. They have this negativistic reel. They can't stop ruminating. And I find atypicals, which may be in part an executive function problem, but I find atypicals very good there. So I think that some of this improvement in engagement that we're seeing with brexpiprazole, which may be norepinephrine related, I don't know, but maybe it's in part because it's giving some patients maybe the ability, because they're not so hijacked by rumination and anxiety and that kind of, all these types of anxious type symptoms that they so often experience.
Yeah, I think you're absolutely right. And if you think about it, some of these agents may be better for that than others as well, to these various mechanisms. And, we're not terribly good right now at matching up the ideal medicine to the particular patient. We don't have good biomarkers, if you will. So it would be nice to have that. And maybe what you're working on there is developing a clinical signature, a clinical phenotype that may respond better to one than the other. And that may help guide therapy.
Yeah, I think so. I think that until we find that biomarker or that biosignature that is, the ultimate in personalized and even precision medicine, we're still, we're clinicians. It's phenomenologic. We're looking at symptoms. And I think we do this intuitively. You talked about, clinicians' wisdom. And I think that, when you see a patient who's more fatigued or apathetic, that shifts you one way or the other. Some patients are more anxious and agitated. But certainly residual symptoms in depression that and I know I'm not alone here, are often anxiety and agitation. Secondly, often a lot of this sort of fatigue, apathy, disengagement. And then you get a lot of this sort of mixed features, which is probably a bit of anxious agitation. And then finally, this whole issue around, just this rumination, which I find is so common in depression. And I find atypicals can really help patients. It's just so relieving for them to have that rumination reduced.
Yeah, I certainly agree. And, if you look at clinical trials of depression, classically exclude patients with significant anxiety. In the brexpiprazole trials, actually, about 50% of patients had coexisting anxiety symptoms, and yet it was equally effective. Certainly, we know quetiapine is obviously very effective for anxiety as well. When you talk about that rumination, it also brings up the cognitive impairment and cognition that I know you've done a lot of work on that, and that's also one of the common residual symptoms.
It sure is. And I know that colleagues joining us for the podcast, Andy, are faced with the question frequently when they see a patient with depression not responding optimally to antidepressant. Does this person have cognitive problems because they have concurrent ADHD? I know, Andy, you could say a lot about ADHD and your work in that area. And or do they have cognitive problems because of depression that's lingering? And I think the very process of thinking about that, I think, is job number one. Just to think that there's a differential diagnosis here. And I was telling, actually, it's interesting, just recently I was telling a patient this, we were sort of going through a careful history. Do you have ADHD? Is this cognitive problems part of depression? And we both kind of chuckled because we both were anguishing trying to figure this out. And we said, heck, why don't we just sort of maybe put the academia aside for a moment? Why don't we just treat you as a patient and just to see what happens? But it's an important question. And I think ADHD, as you know, Andy, is very common in depression. And also lingering cognitive problems affect about half of people with depression. And we very often will use off-label psychostimulants, modafinil, other cognitive enhancers to target that. Many would know by now that 40-oxetine has independent effects on cognition in depression, but we also look at a whole variety of other strategies to try and remedy that. And also in the psychotherapeutic realm, like cognitive remediation, maybe exercise is helpful in those regards as well.
Yeah, I completely agree. And since you brought up the comorbidity, and we forgot to mention earlier when we were talking about adjunctive treatments, the psychostimulants, there's a very common cause, if you will, or underlying etiology of treatment-resistant depression is ADHD, because you're usually going to start with an SSRI or SNRI, and they're not terribly effective for the cognitive aspects of ADHD. And as many as 40% of ADHD patients at some point will have comorbid depression. So that's a very important clinical pearl in your kind of non-responsive or inadequately responsive depressed patients to really go for ADHD and think about it. When we're talking about cognitive impairment too, the pattern of cognitive impairment is kind of similar. We're not talking about dementia. We're talking about problems with sustained attention and working memory predominantly, which undergird both of these.
Absolutely. And we so often see patients, we talked about rumination where the patient cannot shut off that negativistic self-reel. It's often very anxiogenic, it's depressogenic, it's very purposeless, it's energy demanding, and it's very upsetting to patients. And what I have found, which is interesting, is the literature shows this is probably a deficit in cognition, in other words, working memory, and also executive functions. And so it's interesting because I have found that in patients who have ADHD, but patients who don't have ADHD, who have depression and ruminate, I have found stimulants helpful. And I've also found in some cases, interestingly, in major depression, where rumination is a target symptom, that some of the atypicals have been very helpful. And patients have said, this treatment is just maybe less sort of self-critical and negativistic. I can finally focus on what I got to do today. And I think it's just a phenomenology that's ubiquitous that we don't say as much about therapeutically.
Oh, I totally agree. And you've talked a lot and taught me a lot about disruptions in networks. And so we're really talking about a disruption in the default mode network and the executive network, aren't we?
Yeah, we really are. And this is a really interesting area. I remember, Andy, when you and I started, it was all about that gigantic neuron, that serotonin neuron. And the whole world revolved around the serotonin neuron. And, the synaptic cleft. But it's really interesting. It's really cool. We have this incredible technology. We can suss out the circuits and the networks in the brain. We really have a motherboard, so to speak. Our brain's a motherboard. There's all these networks and circuits. The default mode network, which is really well characterized, really two things going wrong with it. Well, first of all, what does it do? It actually is a network that subserves self-referential thinking, that sort of, reflective thinking, daydreaming, reflecting on yourself. It's an important part of our lives. But in people who have depression, two things wrong. First, it's kind of in overdrive. There's this over kind of self-reflection. And secondly, it's not kept in check and balances by some of the other circuits like the cognitive control circuit. So it's a bit of a kind of a wayward kind of network. And then with treatment, which is really interesting, when patients subjectively begin to report less of this agonizing rumination, et cetera, that coincides with a greater what they call reciprocity with the other circuits. In other words, it's kind of more kept in check and balance, so the circuit connectivity is corrected. So I think we're moving more on that sort of framework, Andy, that kind of conceptual framework or heuristic. The field's talking more and more about the connectome, and there's something wrong with the connection system in the brain, and that really our drugs, they really initiate a molecular cascade of events that lead to eventually a resetting of the connectome. It's a very interesting area.
It certainly is, and I like that. I like going beyond, just dipping as Steve Stahl would say, dipping the brain into a bucket of serotonin is what the SSRIs do. And this more sophisticated concept. And something else you just mentioned that's interesting to me is, for a long time, we were taught about a sort of deficit model, that there was a decrease of monoamines and a less activity in parts of the brain. But what we're actually learning here, as you've said, is there's actually overactivity of one part of the brain and maybe underactivity of others.
Yeah, absolutely. And I think the way I've kind of shifted in my thinking over the years as more and more data has come out and we've tried to update our thinking and our models on this, I think it comes down to a dynamic, almost reciprocity at the circuit level, at the cellular level, at the molecular level. It's just like seesaws. You have all these things in interplay. And when one goes up, one may go down, so to speak. And there's all this dynamic interplay. So I think you're right. I think I guess it's Occam's razor. We're always looking for simplistic explanations for everything and so on. And I think that serves us a purpose. I always say, Andy, that look, a bumper sticker serves a great purpose. A nice slogan is a great way to remember something, just say no to drugs. That's a great slogan. But it's more complicated than that. And I think that when it comes to the brain, I just sort of really been, frankly, just intellectually so intrigued by the literature looking at brain topology, where the mathematician gets in there with all their computers and says, oh, this circuit is out of kilter with that circuit, and your psychotherapy, your ECT, your TMS, your medication resets that circuit. And that has a certain coherence to it. I think it's more encompassing and more explanatory than just looking at a synapse of the serotonin system,
Yeah, and don't you think that parallels clinically what we do? In the real world, I'm not sure we treat diagnoses as much as we treat symptom clusters.
Yeah, absolutely. And I think in addition to treating symptom clusters, I think that clinicians, for example, you'll see a patient who's 20, 25, 26, they have depression. And then around 28, 29, they come in and their friend or their relative, their loved one will say, I think this person was spending a lot of money. They're up all night. They're racing thoughts. You think, oh my gosh, this person's had bipolar all along. So there's this kind of diagnostic transition that takes place in some patients. And we see this in psychosis or other conditions. So not only do we have this phenomenology that's not specific to any diagnosis, but within individuals over time across their developmental trajectory, there's this phenomenological heterogeneity. And I think it's an interesting area. So I think that when I think about, for example, we talked about cognition a moment ago. For me, cognitive impairment in Alzheimer's disease in my world is not synonymous with cognitive impairment in depression.
Exactly.
But I would say that there are aspects that overlap, but they're different, but there's some aspects that overlap. And in some cases, there are treatments that overlap. So we end up actually having more domain-based treatments rather than we have disease-based treatments.
Yeah, I certainly agree. And I think clinicians tend to put the medicines in buckets. And I'm thinking specifically the atypical antipsychotics. I always say there's two buckets. There's sort of the sedating weight gainers, and then there's the less weight gain, more EPS kinds of drugs. So maybe calming, sedating versus activating. And I think we pick from the buckets based on the symptom presentation of the patient. You alluded to that earlier.
Yeah, we sure do. We absolutely do. And I think that I think it's not unreasonable.
No.
In the future, to be informing our decisions, I think phenomenology is not going to go away. I just think that maybe there will be some point of care technology, passive, ambient, collected technology that maybe pick up some biomarkers or biosignatures that will further inform the process. It no longer seems too kind of Las Vegas tech show. It actually feels it could possibly happen,
Oh, I completely agree. And I think there's various digital technologies as I'm, I consult with pharmaceutical companies as I review protocols. There's various interesting technological ways of monitoring patients and of looking at subtypes of patients, including, EMA, ecological momentary assessment.
Yeah.
Various ways of using your cell phone, which has a wealth of data, mining the GPS system to see how active you are, looking at how often you're texting and interacting with other people, phone calling, and various other things, facial recognition technology, analyzing the prosody of your voice. So maybe some of these will pan out to selecting the appropriate agent.
Yeah, you're absolutely right. It is amazing. Andy, I just had an afterthought, something we didn't say too much about. We're talking about treatment-resistant depression or suboptimal antidepressant response. But just to go back to that point about bipolar, I think you're going to agree with me that I think we got to always just be on the lookout, probing for patients for bipolar at that initial consult.
Yes.
But also, if they screen negative, if they've got no hypomania or mania at that initial consult, that doesn't mean that it couldn't happen 5-10 years later. So
absolutely.
And just keeping that in the back of our minds. And I think that's certainly the first rule of the day when it comes to non-response to treatment. One of the first rules of the day, many of them, I guess, is make sure the diagnosis is correct.
Yeah, I think now we're probably looking at unipolar MDD as a diagnosis of exclusion. I mean, we're obligated to rule out bipolar first. There's no question in my mind about that. So the consequences are so severe of missing it and then using a traditional antidepressant that's not going to help bipolar.
Yeah. Absolutely. And I've had many colleagues ask me, I'm sure that you've been asked this too, Andy, that they'll say, well, I have a patient who has depression and the symptoms are not entirely fitting into the bucket of major depression or bipolar, but they responded to an atypical. So that must mean they have bipolar.
Yeah.
And I said, I don't know that you can pharmaco-dissect the patient like that. I said, because you know what I mean, right? Because the atypicals can work in both buckets.
Yes.
But it's obviously a piece of evidence when you think about it, but I don't think it pharmaco-dissects the diagnosis.
Well, you've done a lot of work on mixed depression. And as we know, patients who have depression with mixed features have a significant conversion rate over time to bipolar. Not all of them do, but some do.
Yeah, absolutely. Absolutely. And the literature does show that if in fact you're depressed I call it the 4 A's, Andy. I call it the 4 A's. Are you anxious? Are you agitated? Are you angry? Are you having attentional problems? If you're anxious, agitated, angry, and having attentional problems while you're depressed, those get me really suspicious. You might have underlying bipolar spectrum. I'm going to keep a very close eye on you that you don't transition at some point in the near or distant future.
Yeah, and I like you've talked about the 5th A sometimes too, which is anhedonia.
Yes.
You mentioned how important that is to look for and to go after because, our SSRIs don't always work as well for that. I wanted to flip gears a little bit. We had talked about the ABC D2 partial agonists. We're thinking about choosing amongst the various atypicals that we have currently that are effective. It's important to realize that the partial agonists differ in two major ways, which leads me to think that for some patients, even if they haven't responded to one, they may respond to the other. So they differ with respect to the ratio of agonism to antagonism, with aripiprazole being the most agonist of the three, cariprazine in the middle, and brexpiprazole the least agonist, more closer to an antagonist. And then the second way they differ is in their receptor binding profiles. And we know, for instance, that brexpiprazole was bioengineered, if you will, to have a different receptor profile from aripiprazole, have more of the higher affinity for serotonin and norepinephrine receptors that you talked about earlier. So, and of course, cariprazine brings D3 to the table that the others don't.
That's right. That's right. And what's interesting about that, Andy, is that just down the road from me in Toronto, just over an hour's drive, just a short drive, as long as you time the commute properly, it's a very short drive, is Buffalo, New York. And Horacio, I know you know Horacio Capote, he's a colleague of ours in Buffalo. Horacio and I, what we did was we looked at a sample of people who came to receive treatment at the Dent Institute at the University of Buffalo. And what we found was we looked at people who had previously received aripiprazole for depression, and it wasn't either effective and or well tolerated, and it was stopped, and they were transitioned to brexpiprazole. And we found that many of these people who did not tolerate or benefit from aripiprazole benefited and tolerated brexpiprazole. And to me, it was a case series. It wasn't a large randomized controlled trial with a placebo, all that good methodology, but it was a real world evidence transition study. And for me, that is indirect evidence supporting what you just said, that these agents are not interchangeable, and I don't think that there's futility in going with another agent if the other one didn't work. Because I've had people say, oh, I tried quetiapine and didn't work. Is there really much point in trying brexpiprazole? I think so. Or I've tried aripiprazole, that didn't work, wasn't well tolerated. Should I consider brexpiprazole? I would not take it off the list of considerations.
I absolutely agree. And this is the danger of the nosology, the terminology of saying antipsychotics in general, because they differ, and then D2 partial agonists as a class, if you will. I think as Steve Stahl says, their differeces are more similar, or their similarities are more different. I forgot how he says it. It's sort of a Yogi Berraism that he uses. With the remaining time, let's shift gears now and talk a little bit about some of the novel agents in development that we alluded to at the beginning. It's a little fully beyond the scope of our talk, so we don't have to get into a lot of detail, but we should talk about some of these. But before we do, I'm going to use a Stahlism. Pop quiz, quick quiz. What was the first prescription antidepressant available in the United States? And you mentioned imipramine. It wasn't a tricyclic. It wasn't imipramine. Turns out it was amphetamine, Benzedrine, 1937.
Interesting.
Was heavily marketed to physicians with the imprimatur of the AMA, interestingly.
Interesting.
So, we mentioned stimulants earlier. They have a very long history of use in mood disorders and can be certainly appropriately used. And maybe we're bringing, dopamine into the picture here, which we know helps cognition and apathy, for instance, and energy.
Yeah, absolutely. Absolutely. Ketamine and esketamine are certainly now been subjected to many analysis and Cochrane reviews and showing, efficacy in people with very difficult to treat depression and in safety and tolerability when used under, proper surveillance and good medical training, et cetera.
Yeah, you've actually published the guidelines on the use of ketamine and esketamine in the American Journal.
Yeah, we did. And it was a whole group of us. And I would say that in part why we wanted to do that was, of course, to speak to some of the science, but also some of the guardrails with respect to practice parameters, the premise, the professional bona fides to do this type of treatment and so on. I think all clinicians welcome a new hopeful strategy for their patients. But I heard across the country people raising, I think, legitimate concerns about kind of, in some circles, giving out ketamine without adequate surveillance and so on, and maybe not quite best practices. And I think we needed to address that issue head on.
Yeah, I totally agree. These ketamine clinics are springing up all over the place too. And, some are started by anesthesiologists and some of them consult with psychiatrists and some may not. So I agree with you. Sort of the Wild West out there a little bit. Okay, let's talk about some novel agents in development for augmentation in particular. Let's talk briefly about some of them. Let's start with the psychedelics. Start with going back to the future here.
Yeah, absolutely. I mean, Humphrey Osmond was a Saskatchewan psychiatrist who coined the word psychedelic. And
I didn't know that.
Yeah, in Saskatchewan. Actually, it's an interesting story, Andy. I'll be very quick. He was treating patients with alcohol use disorder, AUD, and he had observed that those patients that had DTs, delirium tremens, were more likely to stop using drugs, alcohol, and maintain sobriety. So he said, why can't I just induce psychosis? And then he gave them psilocybin. Albert Hoffman, of course, famously synthesized it back in 1938, and he accidentally used it in 1943. And of course, psilocybin comes out in 1958. Short story, we're going to learn later on in the fall of 2021 whether some phase 2 studies are positive and safe. Compass Pathways, a few other groups are looking at this. If it's positive, we'll see where it goes. Secondly is the area, and there's other derivatives like ayahuasca, DMT, and ibogaine, things, and we'll see where they go. What's interesting to me is also the MDMA, methylene dioxymethamphetamine, so good old ecstasy, and its efficacy in PTSD was recently reported in a very nice study, and there's some nice data in other areas as well. And so I think that the psychedelics are not prime time, but there's some promising leads that are happening right now. We'll see where it goes.
Certainly. There are some others in development. Are there others at your liberty to speak about?
Yeah, absolutely. So we know that brexanolone we know is approved for postpartum depression, but we also know that there's other related drugs like zuranolone, which is an oral, a type of positive allostatic modulator of GABA. Andy, as you know, there's a combination pill of bupropion and dextromethorphan that's waiting for FDA final decisions. That's dextromethorphan, the antitussive, has also got glutamatergic, among other types of activity. That's very interesting.
Yeah, I
and
agree.
then you mentioned the trace amines. That's more, of course, looking at in schizophrenia, but we also know that people are looking at orexin antagonists in depression, which is really, I know you know a lot about that. And people are also looking at other types of glutamate drugs. For example, there is an isomer of methadone that's being looked at in depression, which I find
dextromethadone,
Exactly. Yeah. So, I mean, there's a few others, but I think that we're talking about, this has been an exciting area. There's lots of new leads now.
Oh, I absolutely agree. There's also a drug called NV5138 Navitor that is an agonist of, now I'm blanking, of course, on the mechanism. Do you know what I'm talking about, Navitor? It's an mTORC agonist.
Yeah, absolutely. That's an interesting area. And I think it's just interesting that we're seeing not just only new molecular systems being engaged, but for example, Neurocrine has a product in their product pipeline that's to target anhedonia. So we're seeing more domain-based treatments, which I think is kind of interesting, going back to our point earlier that these domains cut across many different diagnoses. So it's a really different ballgame. And then finally, I think what's interesting, Andy, is that with telehealth and telemedicine, e-health, m-health, there's now more studies trying to integrate digital psychotherapy into the pharmacotherapy, which I think is really timely given what happened with COVID.
Yeah, I think you're right. And I think we've all kind of had a crash course in how to use digital evaluation and monitoring and treatment. As you said, there's definitely digital therapies. Some of the other, and these are informed by the technology, as we mentioned earlier, and they understand the pathophysiology. I mean, if you're talking about an mTORC inhibitor, for instance, that's even going further up the pathway than the NMDA receptor. We think that may be sort of the final common pathway. And another agent in development is a TrkB agonist, which is the BDNF receptor. So thinking that if you stimulate that, you may be, and maybe the final common pathway is BDNF generation. So that's
that's very interesting. That's really interesting. And I think that, we talked about ketamine earlier, and, ketamine, as you know, targets NMDA, but we have 3 ion channels, over half a dozen metabotropic receptors.
Yes.
So because we have new technology that gives us surreal insights, that's opened the door of possibility to many repurposed drugs or even de novo new agents.
Yes.
So and look, I know you and I have been doing this a long time. I'm sure you're like myself. I feel like a kid in a candy shop right now with all the new things that are happening right now.
Absolutely.
It's really been quite awesome. And it's obviously at the end of the day, it's hopeful for the field and hopeful for people who are affected.
Yeah, I mean, talking about going back to the future, we talked about amphetamines and the psychedelics. There's another area that's going back to the future, and that's the kind of the rediscovery, if you will, of the opioid system.
Yes.
And we are all familiar, sadly, with ALK 5140, I think it was called, the Alkermes drug, which was buprenorphine and samidorphan. But there now are a number of kappa opioid antagonists. We know the opioid system, of course, we have the 3 classic receptors, and mu, delta, and kappa. And if you stimulate mu and delta, you can improve mood. But if you block kappa, you can improve mood. And these receptors are tightly linked to the dopamine system and other monoamine systems. So that's another fascinating area, I find.
It is a fascinating area. And it reminds me, Andy, I remember when I was a resident in psychiatry, and I remember I took an interest in mood disorder pharmacology research. And one of the early studies that I wrote the protocol but didn't get funded was I wanted to look at ACE inhibitors. Remember ACE? To treat cognition and reward in bipolar. And there was this old literature that still exists, of course, that ACE inhibitors could not only inhibit ACE, but they could inhibit enkephalinase in the brain.
Wow.
And enkephalinase, as you know, enkephalins are the classic agonist for the delta opioid receptors. And so opioids have kind of been around, but we haven't really taken the bull by the horns and really studied them until recently with some of these agents that you're referring to.
Yeah, I can understand there's such a stigma around the word opioid and certainly the mu receptor, but hopefully we're getting past that a little bit and getting more sophisticated.
Yeah, for sure, absolutely. And people, of course, will have experience with that, with the new agent, olanzapine, samidorphan. They'll understand this treatment from a metabolic perspective, that is having a less weight gain liability than olanzapine. But I think what you touched on is really interesting. That is aspects around anhedonia, aspects around vitality, well-being, mood. These are the wheelhouse of opioidergic systems, and I think I think there's an opportunity provided by some of the agents that we spoke to.
Yeah, I mean, you may remember the opium cure, the famous opium cure, and Brompton's cocktail was used. So there's a long history of manipulating the opioid. And there's a lot of clinicians out there who tell me they use buprenorphine for treatment-resistant depression, too. Good results. So. Okay, well, let's come around full circle. Certainly, I hope the audience is catching some of our enthusiasm about all of this, which is really exciting. But, certainly we want to maximize the use of the tools that we have right now. And various studies have shown a vast underutilization of the atypical antipsychotics as augmentation for depression, despite, as we mentioned earlier, having a very robust evidence base. As a matter of fact, of the patients who get augmentation, something like 10% get atypical antipsychotics. And typically, you go through 5 different lines of therapy until you get to an atypical antipsychotic. And I guess I get it, Roger. I mean, there's a risk, there's the side effects and risks, but what about balancing out the risk of inadequately treating depression?
What you're touching on, Andy, I think is probably one of the most powerful messages of this discussion, and that is that we have an implementation gap. In other words, the science tells us X, but we often do Y. And of course, we welcome new treatment discoveries, but many people would say, hang on, hold your horses. If you would just close that gap between what the science is saying and what you're actually doing, you can make a world of difference now. And I think that you're right. That statistic you just mentioned is really quite concerning. And I think that if we can get people to receive FDA-approved or clinical practice guideline evidence-based treatments sooner rather than later, that will make the world of difference for patients. And I think it's a really important point. This whole issue around implementation science, we don't emphasize as much.
Well said, Roger. And I agree with you. That may be the real theme of our talk today. And maybe part of the implementation gap is, I understand there's always cost and access and insurance issues, but maybe the bigger part, at least for the atypicals, is, again, concerns about the risks. What can we do to mitigate some of those risks?
Yeah, absolutely. And I think that, first of all, look, the risks are established and everything has side effects. But I do think that, to our point earlier, the risks are in many cases dose dependent. So, of course, start low, use the lowest effective doses. Don't give more than you need, but don't use less than you need. Second, I think that, look, not all side effects are a fait accompli. They're not a done deal. There's ways you can prevent it, in terms of your dietary choices on weight gain, or whether it be aspects around, exercise and so on. Now, on the issue of akathisia and EPS, I would say for me, Andy, the biggest issue is let's get rid of, in Toronto, the residents are often trained, put everybody on Cogentin prophylactically. And so there's things that you can do that can lower those risks, be cognizant of drug interactions. So just good medicine. But I know that people, when they read those adverse event lists, they think I'm getting that for sure. And that's an expectancy bias. But there's lots that we can do to mitigate some of these risks.
Oh, I absolutely agree with you, everything you've said. And I think also the choice of the atypical, and they vary with respect to their risks, as we talked about. So certainly switching between one or the other is very reasonable. It's funny, Roger, you glossed over exercise, which is unlike you. It's one of our favorite things to talk about. And there's obviously an evidence base of exercise as augmentation for depression. And I think it also helps mitigate the weight and metabolic issues. And I'm not nihilistic about exercise. I preach it regularly. And I find that if you keep after it, patients, because some patients are intimidated, they think I have to lift weights like Arnold Schwarzenegger, but no, it's really just various forms of activity. So
well put. I agree.
Yeah. All right. Well, again, I hope people are catching our enthusiasm. I love that final point that we're ending on, which is let's really maximize the tools that we have available to us now and try to bridge that implementation gap. And one of our themes has been the reexamination of atypical antipsychotics as augmentation for inadequate response and treatment-resistant depression. We've also talked about, of course, getting the diagnosis correct and making sure you're using our tools appropriately. Roger, any final words?
All well put, Andy. No, I think that's really key. That implementation gap is really, I think, the near-term opportunity. We got some really exciting areas in the pipeline, so stay tuned. And Andy, always fun. Great discussion. Really enjoyed it.
Yeah, I agree. Me too. And so thanks very much. And stay tuned for the other podcasts in our series. And I want to thank everybody. And for more information, you can go to our website, www.neiglobal.com. Thanks very much. Until next time.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.